Okay. Hi. Thanks for having me here today. My name is Katie Wunderlich, and I'm the Executive Director of the Health Services Cost Review Commission, which is a hospital rate-setting body in Maryland. And I'm really actually very glad to be following the last panelists who talked, Mr. Ryan in particular, talked about the obstacles of integrating, paying for community health workers and getting community health workers into the business model, the model of delivering care across the care spectrum. And that's really what I kind of want to talk to you guys about today. I want to talk about how Maryland has promoted the use of community health workers, including financing, and the financing piece for the hospitals that we regulate and other community organizations that can be one of the barriers, because as you know, the services that community health workers provide often are not reimbursed. We have a unique situation in Maryland through our model, our hospital delivery model, where we have a value-based approach that will allow hospitals to use revenue that they have for community health workers and other services that aren't reimbursed. Mr. Jordan also mentioned, a previous panelist also mentioned the focus that community health workers have received across the state, including in the state legislature. And so through the hospital delivery infrastructure, we're trying to also promote the use of community health workers to provide community health and population health for Marylanders. This is not in any way the universe of community health workers in Maryland, but I just wanted to give you a little sense of what we're doing through our regulatory process and what hospitals are doing to employ community health workers and address population health in their communities. So first, just a little bit of background on the HSCRC. We are a state agency tasked with maintaining the all-payer hospital rate setting system, and so our primary duty is setting hospital rates. However, as health delivery has evolved nationally and in Maryland, the state is expanding its approach to delivery in Maryland to break down silo sites of care and coordinate care for patients across the care setting. So the HSCRC is leading this statewide healthcare delivery transformation under what we call our all-payer model. It's now expanded to the total cost of care model. So just a little bit of context for our regulatory agency. A little background on the total cost of care model. Again, the model is designed to coordinate care for patients across both hospital and non-hospital settings to improve health outcomes and constrain the growth of costs. The payment framework for hospitals in this model is a value-based one. We're moving away from a volume system. Moving towards a value-based system allows us to pay for and incorporate those other health services and social services that can keep our communities healthy, to promote health, promote population health. It gives us a structure for us to use revenue that's generated in a hospital for those other purposes. We are the model is a provider-led effort. We're focusing partly on sustaining rural hospitals, and then finally, but not least at all, is focusing on population health improvement. So we have incentives in place in the hospital to manage the health of the population that the hospital serves outside of its walls. And so we really are trying to move in that direction of breaking down the silos and coordinating care across the care spectrum. So to that end, we have been working at and looking at how we can incorporate community health workers in our hospital's delivery system. In 2015, the Commission approved a 3-year program for hospitals to train and hire workers from areas of high economic disparities and unemployment. It was a $10 million grant over 3 years. Hospitals also had to match half of that grant. Hospitals had to train, hire, and support workers to fill new positions designed to improve population health and further the goals that we've set out for ourselves under the total cost of care model. Really, the goals here were twofold. One was to improve the socioeconomic status of disadvantaged communities by increasing employment opportunities. So the hospitals that were involved in this program were instructed to look to train and hire workers from specific zip codes. And we know that stable employment is a critical social determinant of overall health, and so we really wanted to get at both using the community health workers to further population health and also to address the social determinant of health in their community by providing stable employment. There were 9 hospitals in this in the collaborative. This was the Baltimore Collaborative. We handed out 2 grants, one to Garrett County and one to the Baltimore Collaborative. The Baltimore Collaborative was much more substantial. They had a goal of hiring 208 workers between community health workers, peer recovery specialists, and certified nursing assistants and geriatric nursing assistants. The program was renewed through FY22, so it will run through June 22, and it will allow the collaborative to continue to work towards training and hiring goals to make it sustainable. The partners, in addition to the hospitals, the program partners were really important in this effort and in this endeavor. They were using the Baltimore Alliance for Careers in Healthcare, BAC. That was a local organization that served as a training coordinator and intermediary with the hospital systems. There are also, they used partners such as Turnaround Tuesday for recruiting, essential skills training, and wraparound services for the workers. And then, of course, technical training for the community health workers, nursing assistants, and peer recovery specialists at each respective organization. Some of our outcomes, this is just through June of last year. We are trying to minimize the reporting burdens on the program, so we only do 2-year reports. So this is through June of 2018. You can see they were able to train and hire about 114 workers. The big majority of that is the community health workers. The training and hiring is continuing through this year, and then will continue on as we've extended the program through FY22. We're looking at the patient care activities that the community health workers, peer recovery specialists, and nursing assistants deliver include care coordination, health education and health system navigation, companion care and patient escort, transitional care, peer recovery, and linking to community services. So, and the activities that they are doing, we're focusing right now on the Medicare population, which is part of our model, but certainly the community health workers and the workers that the hospitals employ will look at all of their population as well. So just to wrap up some of the insights and lessons learned, one, that there was a slow startup, sometimes new ideas and big ideas, and this is certainly not using community health workers is not a new idea, but using hospital rate setting system dollars for that purpose and producing a collaborative among Baltimore City hospitals was a new idea. So it did take a little bit of time to implement. You saw that there was only 114 workers. They had a goal of 208. We want to continue to build towards that. Second, and we've heard this time and again on the panels, that the community partnerships are really critical. The community, it's critical to recruiting, to retaining, and also for the wraparound services for the workers to help with worker retention. The next bullet, challenging to quantify the impact. This is really from the rate setting commission side, the funding side. We try to put forth initiatives that will have a return on investment. It is hard to quantify what the return on investment of one community health worker that's embedded in their hospital's larger population health initiatives, what that one community health worker return is. So it's difficult to quantify, but certainly valued, and which is why we renewed the program. There was broad community support for this when it came to our commission last year. There were very powerful stories from workers about the impact of the program on their lives and on the lives of the patients that they serve. And then finally, we're hoping that this program and programs like this will provide upward mobility for workers in the hospital delivery system and the larger healthcare delivery system. Thanks.